All right, well, good evening. Thanks for having me back. How many of you here were here when I did this last year? Oh, okay. I'll just let you guys run through the slides. It's the same program, but there's been a few things that have changed, and so some of it is just going back through and reviewing the anatomy and why we do what we do. And then we can turn it into more question and answer type stuff as well, because you guys have already heard a lot of the nuts and bolts, but once again, one of the biggest problems that we run into is stroke is about 1% of our call volume for EMS. So we don't see a lot of them. And how many did you say, Haley, that you have in a year, typically?
35 to 50.
Okay. And do you know how many of those are presented EMS versus come in by car?
Not off the top of my head.
Okay.
But
The typical numbers, nationwide, they say 70% come in by EMS. In Des Moines, at Mercy, it's closer to 55%. So there's still a lot of people that are driving into the ER with stroke symptoms. So they're not calling 911. It's getting better. Unity point numbers are a little higher. Don't know why. I don't think there's an education system there that they're doing something different, but maybe they're just collecting their numbers a little different. I think their numbers are closer to like 80% come in by EMS rather than by car. So anyway, it's kind of a rarity, but it is a time critical diagnosis, and it's one of the only 3 time critical diagnoses where we're pretty sure that EMS makes a difference. The nice part about it is I don't know if this study was done. If we talked about did we talk about the Rhode Island study last time? I don't remember when that was published, so that might be a little bit of new stuff that was is exciting for me as an EMS provider, and as exciting as you can make studies be, I guess. So my background, again, I've been involved in stroke care since 1989, I guess, and was involved in some of the stroke trials down in Kansas City at the hospital where I was working. The trials that were the National Institutes of Health approved TPA. It was a multi-center trial. There were 26 hospitals, I don't remember the number, across the country, and I just happened to luck into that position. It was not by design. It was, I think, as I mentioned the last time, it's what happens if you don't show up at the staff meeting. You get volunteered to do something that's new, and stroke was new, and we had no idea what we were getting into, and it's turned out to be a happy accident. So there is some new stuff in stroke. There's some new things that were brought out at the International Stroke Conference in February this year. Not a lot that is pertinent to EMS, but there were a few things, and one of the things that they did is they kind of debunked some of the things that they were hoping would work. We'll talk a little bit about that. So not a big deal for us in the EMS world, but they did do work on approval of a new drug, tenecteplase, and we'll talk some about that. Haley said that the hospital here is going to start using that after University of Nebraska. They're starting to use it as well, and so once that happens, that change will occur here in the hospital. Once again, not a big impact on EMS, but it does have an impact because it's a bolus push drug. There's no drip. So who's doing your transfers to get patients from here to thrombectomy? Do you guys do those, or is it another service that comes in and does it? Or
typically, it's usually a company out of Omaha.
It goes back and forth probably between Pioneer and these guys.
Okay.
Pioneer's at other companies.
Okay. And so, occasionally, because stroke is a time-critical diagnosis, and I retired out of the fire service. I was an operations chief for 14 years. I understand that I don't want you on the road to Omaha because that's the time when we have the other crashes, fires, things like that we're supposed to be here to take care of. But the flip side of that is being the EMS system is that stroke is a time-critical diagnosis, and we make a huge difference in stroke care. Thrombectomy is one of the only. When you start looking at evidence-based medicine, you start looking at things called numbers needed to treat. And so if you have a headache and I give you Tylenol, if you read through that whole pamphlet of Tylenol in a number 1 font, you'll find in there somewhere where there's a number needed to treat. How many patients with a headache do I have to give Tylenol to before we actually have benefit? And those numbers, depending on the drug, depending on the procedure, they're in the 50s to thousands. but it's still considered a good, safe drug, a good, safe treatment, things along those lines. It's very rare to have low numbers in your number needed to treat. Even if you're talking about cardiac disease, if I'm having stable angina, I know that if I go out and run around the building 3 times, I'm going to start having some chest pain, a little bit of shortness of breath, and I sit down and it goes away on its own. I don't have to take a nitro or anything, and I can do that, and next month I'll do the same thing, and next month. So I've got a very stable disease process. If I go in and have that stented, the number needed to treat to show absolute benefit, that I actually made a benefit in the patient, is close to infinite, because there's no demonstrable benefit to do that, and that's why they don't stent stable angina. It's just, you have to do 1,000 or more of those procedures before you figure out that, oh, hey, this is actually beneficial. If I'm having a STEMI, the number needed to treat is still, I don't know the right number. It's above what it is for stroke. For stroke, if a large vessel occlusion to go into the lab, remove that clot, the number needed to treat is like 2.1. So for every 2 patients that go to the lab with a large vessel occlusion, 1 patient has improvement in their outcomes. So it's one of the few disease processes where we really can make a difference with the process. Try and talk about things that are evidence-based, so there's always new stuff coming out, and that's one of the things. There was a presentation at the Iowa Stroke Conference last week, or a week and a half ago, that was really interesting. The physician explained the whole process of the guidelines. We're operating on the guidelines for treating stroke, and it's the 2023 guidelines, I think, are the most recent ones that are out, and the reason for that is the guidelines process takes time. And science is operating faster than what the guidelines can be printed. We run into that same problem in stuff that we do in the fire service and in EMS. There's always people out there doing something and finding a better way to do something that maybe hasn't had evidence-based backing it, because that evidence-based process takes time. So sometimes there's just common sense things that we can do. Patient positioning is one of those things. We'll talk about that too. So, kind of a review, what's the accurate treatment window for giving somebody the magic clot busting drug? It doesn't matter whether it's TPA or TNK.
3.5.
Say again?
3.5.
4.5. It's not a choice.
Could go either way.
Say again? 4.5? Okay. Anybody else?
6.
Okay. 3? Okay. And the answer is it depends. All of those numbers are actually accurate, not necessarily for thrombolytics, but Mercy is now going out to 9 hours, depending on what's going on with their imaging status. So the imaging has gotten so much better over the years with the CT angiography, CT perfusion. And I was going to ask you, Haley, are you guys doing CT perfusion?
Yes,
Okay.
not very frequently, but we offer it.
Okay. And do you use that to determine and then send it to the university to see if this patient's going to be accepted? Or yeah,
Typically, yeah.
Mason City does the same thing, and it's made a big difference for them. So they're really having some good success with it. And I've got a case study actually from there that I'll show you. But if you read the pamphlet, FDA says 3 hours. That'll never change. There's good science behind 4.5 hours, and that's what everybody's using. All of the stroke centers across the state have said, yep, 4.5 hours is the standard that we're using. So from the last known well to the time that the patient gets the drug, so that the drug is pushed for that initial bolus dose of TPA or the whole dose of TNK, that thrombolytic has to be done within 4.5 hours. Docs are reluctant to go beyond the 4.5 hours because there's some potential downsides. So, and we'll talk more about those in a little bit. But with some of these imaging things, DWI is diffusion weighted imaging. Thrombectomy is just the 10-cent term for going in and mechanically removing that clot. So they're going to go in. If the clot lodges in a vessel that's large enough, then they can go into a specialized cath lab. It's not the cardiologists that are doing it. These are neuroradiological interventionalists. And they go in and they'll either use a stent retriever or they'll aspirate the clot. They use suction to just aspirate it. And that's what thrombectomy is. It's a mechanical removal of that clot.
What's the time frame for that then?
And that's where you get out to your 24 hours and then ... And the reason is that they're now looking at going beyond 24 hours. But the 24 hours is magic because 24 hours is typically the standard for thrombectomy if this is a large vessel occlusion. And the reason that impacts us in the EMS world is that's where our definition of an EMS stroke alert comes from. If we have somebody who has the acute onset of neurological symptoms that we think is a stroke, their blood sugar is normal, and their last known well is within 24 hours, that's a stroke alert. Because it could be a large vessel that can be shipped out, flown out, whatever, and can be treated. And Mercy has gone out, they've gone out to 30, I think 32 hours was one that they did a few weeks ago. As their stroke coordinator was talking about it earlier this week, they said it depends on the patient. You know, a little old lady who's 104 years old and has very tortuous vessels when they do the CT angiography, and all of the vessels look like, you know, Arkansas roads, then they're probably not going to go after that clot because the risk outweighs the benefits. Whereas a 36-year-old person who has a large basilar artery clot that's easy to get to, even though their last known well was, you know, 33, 34 hours ago, and they have major deficits, the risk benefit is in the patient's side to go ahead and go after that clot. So that's why there's the dots, is that it just keeps growing. That time window grows as they get more experience with doing the mechanical thrombectomy. Magnetic resonance imaging and MRA, do you use any of that here, Haley? You using any
We have
MR?
the MRI, but we don't typically use it for ER patients.
Right, and that's
available,
true even
yes.
at the university and at Mercy and the bigger stroke centers. I don't know about University in Omaha, but most of them, they reserve MRI for the weird cases, and they do it to confirm that, okay, I've got a patient that is having stroke symptoms. We did a CT angiography. We looked at their blood vessels, and we can't find a clot. So there's something going on here. We need to find out what it is. MRI will find it. If it's a stroke, they'll find it. So that's what they'll use that for. And then we'll talk some about the guidelines, what the new guidelines are. So this is CT angiography on the right, or I guess it's my right, on your left. And then this is a CT perfusion study. And I may not be able to see it real well from across the room, but the concept is by using a CT scanner and dye, they'll actually look at the blood vessels. This is the middle cerebral artery right here, and it's missing over here. That middle cerebral artery is considered a large vessel occlusion. That's one that they can go in and retrieve with an aspiration device or a stent retriever. And they have really, really good success. Again, 1 out of 2 patients that go are going to have benefit. The CT perfusion study, this is really cool. It's relatively newer, but what it does is on this half of the slide here, you can see that there's some pink areas in these slices on that CT. The pink areas are dead brain. That's infarcted tissue. We can't get that back. It's done. The green area is the area of tissue that has hypoperfusion. This is ischemic area. It's being fed either by the collaterals or it's dying as we speak because Mrs. Jones just had her stroke. So then the computer will actually come up with a ratio, and it'll give you a mathematical computation. And this one is 17.1, which is really big. There's a lot of salvageable brain tissue on this patient and very little infarct volume. The infarct volume on this one is actually 8 milliliters, which is it's a tiny stroke, but it's going to turn into probably a fatal stroke if we don't do something to remove that clot. And this can be done in about, I don't know what the time frame is, I think it's around 20 to 30 minutes. So, and with the software, it actually gets, you know, the stroke coordinators and the docs, they can actually get it to their phone. So they see it right away. And then if this patient is a candidate for thrombectomy, we know, okay, we need to be greasing the wheels and getting things going to get this person off to thrombectomy because minutes count. Everything we do is shaving minutes off because, and somebody did a study, and I don't remember the real number, if it is a real number, but there's so many million brain cells are dying every minute that there's no perfusion. And I'm sure it's accurate. I don't remember the real number. The concept is, though, that the longer we wait to remove that clot, the more brain damage is occurring. So we're turning green into pink, and we don't want that to happen. So that's what some of the imaging things are doing, and it's allowing those physicians to have that conversation with either the patient or the family members and saying, here's the risk of us, either flying you or sending you by ambulance to a thrombectomy center, and they're going to put a catheter into your groin, and they're going to go up and they're going to remove that clot. And here's what happens if we don't do it. And so the time windows, they're still important. We still need to be able to collect that information, but it's now being done in conjunction with the imaging for them to make a better informed decision. Does that make sense? We already know it's 1% of the call volume. We know there's a lot of stroke mimics. This is kind of interesting. There's a study I'll talk about a little bit later. It's the one out of Rhode Island. But one of the things that I was really pleased to see when I went out to the International Stroke Conference, now this is 6,000 neurologists from all over the world that all they do is, their forte is stroke care. So, and everybody's documentation, everybody's presentation, all agreed in every country, EMS makes a difference. And it's kind of interesting, because if you read in GEMS, maybe 5 or 10 years ago, there was an article, and it was actually published by USA Today, and they said, you're better off taking a taxi cab to the hospital. You have a higher survival rate in major trauma than you do if you call 911. Now the interesting part is that study was actually done in Malaysia. I have no idea what their EMS system is like, and there's even people that have questioned it here in Iowa. If I'm in East Overshoe, Iowa, and I've got a volunteer service, which 70% of our services in Iowa are still volunteer, am I better to call 911 and see if they can get a crew, or do I take the patient to the local ER myself? I don't have a right answer, because every circumstance is going to be different. We know the data says that if you use EMS, you have a better outcome. Your door to treatment time is shorter. So areas especially where we have people in the stations, or we've got a really good, robust EMS system, whether it's volunteer or paid, doesn't matter. If they can get in and get a crew out the door, and they can transport that patient with early recognition and notification of the hospital, that increases treatment rates, it decreases the door to CT time, it decreases the door to evaluation time by the doc, and it also, the weird part is, it does increase treatment rates. Patients don't fall through the cracks as much. And the theory is, just like in the trauma systems back in the 80s when they started legislating the trauma system, if I'm out on the scene and I see the mangled wreckage, and I go, gosh, how did anybody live through that? And my patient's awake, alert, and oriented, pink, warm, and dry, and they're standing outside their truck going, holy crap, what happened? And they don't look sick, but you go, this happened 5 minutes ago. You still got an adrenaline dump going on. We're going to get you in, get your vitals, and we're going to transport you to the hospital. And now all of a sudden, maybe you aren't looking quite so punchy, but we relay that information on and say, I think there's a potential this patient is hurt bad. This is a trauma patient. Those patients didn't fall through the cracks nearly as much. That was part of the basis of the trauma system. Same thing's happening in a lot of different countries now, and that's the fun part about it, is we're seeing it happen in different countries as well as in the United States, that all I have to do is put the word stroke in there somewhere. Hopefully it's more formalized than that. Hopefully it's, I've got a stroke alert. This is why. My patient has right-sided paralysis, facial droop, they can't speak, and the last known well was 2 hours ago. Here's their medications, here's their vitals, and we'll be there in 10 or 15 minutes. That 10 or 15 minutes gives the hospital a chance to expedite the care again a little bit. And it doesn't take much, it's just minutes. What do you have for CT? Do you have somebody in-house CT 24/7? So,
We go on call.
do you call them in based on a stroke alert?
Yes.
Okay. So, getting that person called in, and then in one of the rural hospitals where I was at, they actually, they said, we trained the EMS providers how to turn on the CT machine. Good. That's great. Was that like a 3-hour class, or, it's the red button over here. But they basically enabled them to do that, and they said, and that saved time. Their door to CT times went down because once you turn it on, it's not ready to go. There's a warm-up time for a CT machine. So just by getting that turned on, now when the CT tech gets in, it's ready to go. So stupid little thing, not stupid, simple little things like that can decrease the amount of time before the drug is given, before the thrombectomy is done. We save brain cells by doing it. And that's what the whole process is boiled down to. That's why it's a time-critical diagnosis. So we do make a difference. We still have some of the same shortfalls, and part of it is making sure that we're using a valid screening tool. Even though we've been doing a lot of stroke education for the last 3 years through the Mission Lifeline grant, and then even before that we've been doing a lot of stroke education, one of the problems we run into is that we're typically good at what we do. I'm a good paramedic, I'm a good firefighter, I have faith in my skills and my ability, but once again, I only see stroke 1 out of every 100 patients. So unless I'm doing something else where I'm seeing more stroke patients, I may not have committed to memory whatever that stroke exam is. In fact, we did a survey and found out, we got the survey results back today. It was interesting, about half of the EMS responders, the people that responded to the survey, about half of them did not know what stroke exam was specified in their protocols. We had 3 people that said, we don't have a stroke protocol. Yeah, you do. You've got to have one. But, so memorizing things, or having some sort of, and that's why we've got the Be Fast sheet there. There's several different exams you can use. We'll talk about the RACE score. It'll be the same video you saw before, but it's a good review. Bless you. And, but the Be Fast is what we're really promoting for healthcare providers. Now, the Heart Association did a study. They looked at it and they said, okay, here's FAST, which is the Cincinnati Prehospital Stroke Screen. It's facial droop, arm drift, and speech. And then T is time, to remind you that it's a time-critical diagnosis, and also to make sure you do what you can to play detective and find the last known well time. So that's the Cincinnati Prehospital Stroke Screen. That's what the majority of EMS agencies are still using. And if you add balance and eyes to that, so you've got Be Fast, now we've got, we're adding a little bit to the anatomy, and that's in the next few slides here. That simple study that they did through the Heart Association was for the general public, and they said, okay, you can use general public, you need to recognize a stroke. You can use FAST or you can use Be Fast. Which one do you remember better? Duh. FAST won. FAST was the one that they remembered better for the general public. But there's some shortcomings to that, so we'll talk about some of those things. So our quick review on the anatomy and physiology. We're talking mainly about ischemic stroke. There are hemorrhagic strokes. The numbers have typically stayed steady. The numbers everybody uses is 87% of strokes are ischemic. So the clot travels to the brain or it forms in the brain. Pretty rare to have the clot form in the brain. It can. There's other types of stroke where that happens. It's still an ischemic stroke. It still gets treated the same. But most of them are the clot will travel. And so it travels, lodges in the brain, and then depending on where it lodges as to what you see for those signs and symptoms. There is good treatment for hemorrhagic stroke, but it's very specific. It depends on what vessel is bleeding, where it's located. Is it in the subdural space? Is it in the subarachnoid space? Is it an intraparenchymal bleed? Can you get to it surgically? And then, is it an aneurysm? Is it an AV malformation? There's just a lot of varieties. What's the blood pressure? Does the patient have a long-standing history of hypertension? All of those things will go into the treatment. On the bigger group, the 87% of the ischemic strokes, it's kind of like STEMI. All STEMIs go to the cath lab. All ischemic strokes, as long as they don't meet if they meet the criteria, the standard of care is to get the clot-busting drug. Problem is, we've got some pretty narrow criteria for that. 4.5 hour time window. We have to have a concrete last known well time. So, and has anybody here, any good stories that you guys have had as far as trying to determine or help determine what a last known well time is?
It's not very easy a lot of the time.
Mm-hmm. And a lot of times you get family members that will tell you different things. You know, wow, yeah, she woke up this morning and she was making coffee and then all of a sudden she couldn't talk. And it's like, well, last night she was having a hard time getting her words to come out right before she went to bed. It's like, okay, which is it? And that's one of the reasons the stroke coordinators have asked us to get a name and phone number of somebody who has kind of a good head on their shoulders, knows what the past medical history is, hopefully knows the events that are going on, and can help solidify what that last known well is. The patient that I showed you earlier that had the big, with that CT perfusion, she was a great candidate for thrombectomy, but they didn't know her last known well. They were speculating that it was around anywhere from 4 to 6 hours. And then once another family member came in, it was another one of those things of, gosh, you know, we don't really know. And then they also found on the CT angiography, her carotid artery was fully occluded, and it was chronically occluded. It wasn't this stroke that occluded her carotid, but she had chronic occlusion. There was no way for them to get the catheter up to actually do the thrombectomy. So she was not a candidate, even though the EMS crew did everything perfect. And you know, they recognized that it was a stroke. They called the stroke alert. They did their stroke exam. They even did a race score. They said, yeah, this is what we think it is. We think it's a large vessel. And they called, and when they went to ship the patient for thrombectomy, the thrombectomy center said, hey, what's this on that CT angiography? You know, the carotid appears to be blocked out. And they said, oh yeah, it is. It's blocked. I said, ooh, well, that, and we don't know the last known well. Patient's not going to be a candidate for thrombectomy because there was just too many risk factors there. So thrombotic stroke, the clot forms in the brain. Cardioembolic, or any embolic stroke, something travels, and it doesn't have to be a blood clot. That's typically what it is. We were talking right before the class started. There was a presentation last week at the Iowa Stroke Conference where they talked about maternal stroke. And it's kind of an interesting tidbit. I don't remember talking about stroke when we talked about our OB patients, but patients that are pregnant, especially as they get towards the third trimester, and even postpartum up to, I don't remember the time frame.
6 weeks.
6 weeks postpartum, they are at an increased risk of stroke. They have some coagulopathies that occur with pregnancy, so there's some odd clotting things that go on, which can go either way. They can either end up developing a bleed, or they can throw a clot, or they can actually also throw an embolus of amniotic fluid. So when I've heard of that in pulmonary embolus, you know, as an amniotic fluid embolus for pulmonary embolus. I hadn't heard of it occurring in a stroke, but that's another possibility. So big chunk of them are ischemic. That's what we're dealing with. There's still good treatment for the bleeds. So your brain will use up about 30% of your cardiac output. As you sit here and try and stay awake, it's there's two things that keep your brain functioning. What are they? Caffeine is not one.
Sugar and oxygen.
Mm-hmm. Sugar and oxygen. If you cut off the blood supply, the oxygen or glucose supply, how quickly do you see the results in your patient?
Quick.
That's quick. It's very quick. So one of the reasons we want to make sure we're checking the blood sugar is that if we have a patient who's diabetic and their blood sugar is dropping, as that blood sugar drops, it's dropping in both hemispheres at the same time. And the reason that's important is your awake centers they sit in the midbrain, and they're on both the right and the left. So it's in what's called the reticular activating system. You don't have to remember that for any reason other than Trivial Pursuit. But that's your awareness centers, and it's pretty rare for me to throw a clot. When that clot gets up into the brain, it's got to go right or left. So when it does that, it may knock out part of that reticular activating system, but the other part of it's still working. That's the reason most of our acute ischemic strokes are still awake and looking at you, and typically very anxious, trying to communicate. They're awake. They're probably not at a big risk for losing their airway. Now, if that clot lodges in the basilar artery, we'll talk about that in a little bit, then they're at a higher risk of decreased level of consciousness. And then if you have somebody who has a bleed and we won't know in the EMS world and in the 911 call, is this stroke a bleed or is this stroke a clot? If their level of consciousness is spiraling the drain before your very eyes, you can pretty much bet on this is a bleed. Those are the ones we need to worry about, maintaining an airway and doing that kind of stuff. And then depending on, so as your blood sugar drops, I may have one side of my head where the plumbing's not as good. Maybe I've got some small twisty blood vessels, again the Arkansas roadways, as compared to this side, which is normal. So as my blood sugar drops, all of a sudden, even though my blood sugar is 50, this side of my brain is not getting as much sugar as what this side is, and I end up with a one-sided deficit. So I have weakness, a facial droop, may have some difficulty with speech, the things that we would see with a stroke. It's not because I threw a clot, it's because my blood sugar is dropping. And that's the reason that we make sure that, in order to be a stroke alert, an acute onset of neurological symptoms, last known well of 24 hours or less, and their blood sugar is normal. If it's not, if it's low, we need to do something to bring it back up. And I know I asked this last time. I think you guys have the latitude to, what are you using for given for IV glucose?
D10 or D50.
D10 or D50? Okay. In stroke patients specifically, D10 it may be a better choice, or give small doses of D50. Stroking brains don't like hyperglycemia. And of course, if I've got a patient who's got a blood sugar of 50 and they've got one-sided deficits, and it's like, oh, I need to hurry up and get their sugar up, so I give them a whole amp of D50. What's their sugar now? Yeah, 400. And stroking brains don't like that either. So get their sugar back up to a normal level for them, whatever that normal level is, and now if they've still got stroke symptoms, it's a stroke, and it's a stroke alert at that point. And so depending on where that clot lodges as to what you're going to see for your signs and symptoms. We'll see if you guys remember from a year ago. What's your frontal lobe do for you?
Take your mood.
Okay, mood, personality, decision making, those types of things. It's pretty rare to have a stroke that only affects the frontal lobe. Can happen, but we don't typically see them. Once again, nobody calls 911 because precisely at 9:45 tonight, Grandpa turned into a raging ass. Sorry, we're being recorded. A jerk. He turned into a jerk. So nobody calls 911 for that as a general rule. But because of the distribution, because of where those blood vessels go, if I have something that affects that frontal lobe, it's probably going to affect the motor strip also. So this strip right here, and then is the motor strip, and then the primary sensory cortex, and the sensory association cortex. And that's your gross motor movements. And remember, they cross. So left motor strip allows me to pick up the water. The sensory strip, I know I've got the water in my hand. I can feel it. I can feel that it's cold. My thumb is up. My thumb is down. I don't have to see it. I know where I am in space. That's all stuff that happens in that particular area of the brain. So if we knock that out with a clot, this is kind of a representation of what's innervated there. Out here on this lateral edge is this area right here on the lateral edge of those strips. So if I knock that out, what do you see with your patient if I lose half of the innervation of my tongue and my larynx? How does that affect me as the patient?
That's your airway.
Yeah, it's my airway. Now it's only affected half, so I'm probably not going to be, in compromise necessarily where I need to be intubated or anything, but I may be drooling, may not be able to manage secretions very well. And speech. You have to have the muscles, the muscle tone has to be there in the tongue and in the face for me to enunciate clearly. If I can't enunciate clearly, then that's the 10-cent term is dysarthria. It's slurred speech. What does it do to your ability to swallow? Yeah, it may be gone. Maybe it certainly could be impaired. And so we don't do anything give anything by mouth for a stroke patient until their ability to swallow has been evaluated. And it's easy to do. If you work in the ER or if you've ever had the opportunity, it's basically you give them little bits of water either through a syringe or a spoon and let them swallow it and see if they gag on it. It's like, well, that was easy. But that needs to be done before we give them anything by mouth. And we're not going to do that in the ambulance because there's nothing that we need to give them by mouth. We need to be focusing on getting their medications, getting their history, getting their last known well time, and getting them out the door to the hospital with a stroke alert. If you move up a little bit more superiorly, you got a big chunk that's the face. That's where you get your facial drooping at. The hand is more superior, and then as you go up across the top part of the brain, you end up with the trunk and the leg. So remember, if you take a cow brain or take your brain and sit it out in front of you and just look at it, you've got that big crevice that runs down the middle, the falx cerebri. You can pull it apart. It's not attached until you get down into here, into the white matter. So this area up here is what innervates the leg. The reason that's important, we do see some strokes, the blood supply comes for that area, comes from the carotid artery, comes up into the middle cerebral artery and the anterior cerebral artery. Anterior cerebral artery perfuses, when you're looking at the brain from the front, it gets this area. All the way from the forehead, all the way back to the parietal area, but it's this tunnel right here. And so that's what's affected. So does this patient have any deficits if you do a FAST exam or a Cincinnati Pre-Hospital Stroke Screen? Do they have an arm drift? This is the interactive portion of the show. This is what's affected.
Yes.
So it's this area here. That's the part that doesn't work. Do they have a facial droop?
No.
Nope. They have any problems with dysarthria or slurred speech?
No.
Nope. Probably don't have any problem with arm drift or fingers, grip or anything along those lines.
My leg quit working.
So yeah, their leg doesn't
That's
work.
the one where they say my leg quit working.
Yep. And if I didn't know that this could be a stroke, you tell me, oh yeah, I'm having a hard time with my leg. It's numb and tingly, and I'm thinking slip disc, or the old football injury, or my grandmother's favorite, you slept on it wrong. So those are the things that could be wrong. I never knew initially before I got involved in stroke. I didn't know this could be a stroke. Now these are rare. Has anybody seen one of these? So it's estimated, and we don't know for sure. It's estimated to be about 5%. And that comes from one of the neurologists at the University of Iowa, because I asked him, I said, hey, how often do you see these? He goes, oh, I don't know. He goes, 5% of the time. It's like, that was a scientific answer. So, but the other thing that will happen up here is because it's also affecting the trunk. These are the patients that, when they'll sit them on the bed. If you got one leg that's not working, when you sit them up on the edge of the ambulance cot or on the bed in the ER, one side of the trunk is not stable either. So they end up with what's referred to as truncal ataxia. They actually will lean one direction because the innervation's not working really well there. So if I got a leg and a trunk that aren't working all of a sudden, and I'm leaning, and it's a sudden onset. This wasn't something that came on over the course of, it's chronic or whatever. We need to start looking for that last known well, and this is a stroke alert. This is a large vessel. The A1 segment of the anterior cerebral artery is easy to get to with a catheter. So they can go in and remove that clot. And this is certainly a disabling stroke. If you can't use a leg anymore, you certainly have a hard time working, doing pretty much anything. Driving, it's a disabling stroke, but it is treatable. This was the one everybody's taught to look for. This is a blockage in the M1 and M2 segments of the middle cerebral artery. And again, don't need to worry about remembering that. Just remember, this is a large vessel occlusion. The reason that this one is done in all of our EMT and paramedic textbooks and nursing texts and medical textbooks is that the clot that likes to live right there typically comes from atrial fibrillation. Atrial fibrillation typically has a standard clot size in humans, and it likes to lodge. If it breaks free and goes up through into the carotids, that's the spot where it tends to lodge because of the size. And that's what wipes out a whole hemisphere. Those are easy to recognize. You've got facial droop, you've got one-sided paralysis. If it's the side where they've got their language centers, then you're going to, they'll have difficulty with communication. And this is the distribution of the middle cerebral artery. So it's, there's a lot of area, a lot of surface area, or a lot of real estate that's encompassed there.
Will those show up on CTAs then?
Yes. Yep. In fact, that CTA that we had earlier, that was a middle cerebral artery. This is the good one. This is where the other one should be. So there's a clot right in that area. And so there should be blood vessels all through here that are part of that middle cerebral artery distribution. So, and one of the things they'll do with CT perfusion is they'll look at this and go, this matches that. Because sometimes you get the patient that they've got the stroke symptoms and you get them in there and you go, oh yeah, look, there's pink dots over here in the left hemisphere. But wait a minute, this is the right hemisphere over here that has the blockage. They've had old strokes, because the old strokes will still show up. So you have to make sure that it matches what you're seeing clinically with the symptoms. Rabbit trail, but one of the reasons that we don't, we need to be very cautious in the EMS world about using TIA is that, for years, we had a definition of a TIA. What is a TIA?
Mini stroke.
Mm-hmm.
It's always a
Mini stroke.
Mini stroke.
Yep. Transient ischemic attack. By definition, and the definition has changed over the years, it's either 12 or 20, the symptoms resolve on their own within 12 to 24 hours, and that was what we defined as what is a mini stroke or a TIA. With the advent of this imaging with CT perfusion, what they found out is a lot of these patients that had a history of a TIA, they came back with either a new stroke or that there was some reason to do a perfusion study on them, found out that they actually had dead brain tissue. It wasn't a TIA. It just didn't, the symptoms resolved because the tissue that was dead didn't impact arms, legs, face, the things that we normally would see. And so about 10 or 12 years ago, they changed the definition of TIA and they said it's 24 hours, rapid resolution of symptoms within 24 hours, back to a baseline, and there's no evidence of dead tissue on imaging. So they've got to have the imaging to show that there's no infarct, whether it's done with perfusion or whether it's done on an MRI, to say that it's a TIA. So the reason that's important for us, when TPA was first approved back in 1996, one of the exclusions to giving the drug was rapidly resolving symptoms. They said if the patient's getting better on their own, don't give them the drug, because there's some potential downside. If we give them the drug, they can bleed in their head and die, and there's a 6% chance that they're going to bleed, and so on and so forth. So they said don't give it if their symptoms are rapidly resolving. That went away, I don't remember what year, it's been quite a while ago, but that word hasn't gotten out to everybody. So we still will see sometimes doctors that are convincing each other. You got the ER doc talking to the neurologist and they're saying, gosh, the patient's getting better remarkably fast. I don't know if we need to treat or not. The stroke systems, the stroke centers that are treating more aggressively will go ahead and treat. The ones that are more conservative may sit on that and wait and watch. And that's up to the physicians. We don't have any control over that. But the key message for us is even if we've got a patient that their symptoms are rapidly resolving, even if they get back to normal and they have no symptoms whatsoever, it is still a stroke alert for us. Because there are some nuances. We may think they're back to normal, but when they get to the hospital and they do a full neuroassessment, the full NIH, there may still be some residual things that we didn't test for. If they had neurological deficits that looked like a stroke, make it a stroke alert. It doesn't cost us anything. Really doesn't cost the hospital, well, according to me, plug your ears. It doesn't really cost the hospital anything for a stroke alert. They're just making sure that the CT scanner, somebody's coming in from CT, the CT scanner's turned on, and we're going to get a non-contrast CT as fast as possible and have the provider, whether it's a nurse practitioner or the physician, see them as soon as possible because this is a time-critical diagnosis. If they decide that, yeah, you know what, their symptoms are completely gone and we can stop the clock, great, that's their decision to make. We don't want to try and make that decision in our world. So from that standpoint, in a 911 call, we probably should not ever be using TIA as our provider primary impression. We can't tell. TIA is a diagnosis. You have to have imaging to get that diagnosis. Now, if the patient says, yeah, I've got a history of TIAs, sure, we know what they are. We can certainly put that into their history. But if I'm presented with somebody who's got deficits and they look like maybe they're having a stroke, I'm gonna call it a stroke. I'm not gonna use the words TIA, because as soon as we do that, same thing we did with trauma, same thing we did with stroke, I say the word stroke, we plant the seed in the ER staff's brain. What happens if I bring them in and I'm not too worried and I say, yeah, I think it's TIA? Same thing, I planted the seed. Now everybody on downstream is going, well, this could be a TIA. And then we have patients that fall through the cracks and don't get treated and stuff like that. So that's kind of the soapbox on what a TIA is. And we should not be using that as our provider primary impression. We can certainly list it in their histories. If we're doing an interfacility transfer and the physician has said they had TIAs and that's why we're sending them on to a stroke center to get more imaging, yeah, you can use it for that. That makes sense. But in the acute setting, we don't want to fall into that trap. So the other areas we've got that are specialty areas, you remember it's Broca's area and Wernicke's area. What do? Because I got the same videos. They're coming up.
Paramedics didn't, or those did.
Well, then where the guy can't say the words right, but he can speak perfectly well.
Yes. So you got these are your language centers, and I'm teaching it a little bit differently. I used to say these are speech centers. Well, one of the neurologists clarified that for me, and it was like, oh, aha, it's a language center. It's not a speech center, because if I've got one-sided facial droop, I've got speech difficulty. I've got dysarthria. I've got slurred speech. That's difficulty with speech. If I knock out Broca's area, this is the area that allows me to form words and to communicate those words out to somebody. It actually is also my writing. If I block it out completely, I lose the ability to communicate through writing as well. Now sometimes you just lose speech and the patient can still write. So that's your expressive communication or language center. And if I lose that one, I'm tripping over words, the words that I want to say, I can't get out. Wernicke's area is back here. This is the receptive area. I hear what's going on, and that comes in, and it doesn't have to do with the auditory nerves or the parts of the inner ear and stuff. It's actually, this is the section of the brain where it interprets what my ear is hearing. So if I lose that, when you say, you ask me to sit down on the edge of the bed, or are you on any medications, I may not hear what you had asked. I may hear, is your daughter home? And so my reply is, well, I don't know where my daughter's at. So you say, well, what medications are you on? Well, I don't know where my daughter's at. And they're like, okay. And so oftentimes this gets mixed up with confusion. We think the patient is confused, intoxicated, or demented, or other things like that. But it's because they can't understand. And there's some easy assessments for it that we'll review back in that video here in just a little bit. So those are your language centers. They're only in one hemisphere. They're not in both sides, as a general rule. Now, again, everything that we talk about in medicine is a general rule. Found out that patients that are ambidextrous, truly ambidextrous, which is a small percentage, it's less than 4% of the population, they actually may have speech centers in both sides of their brain. Learned that from an occupational speech therapist who was, because we're doing more with therapy stuff and involving them in the stroke care. And they said, oh yeah, they said, had a patient one time that was ambidextrous. They had a stroke. It knocked out their speech centers, but rehab was very, very quick and easy because they were ambidextrous. So the other speech centers kicked in for them, and they said it was very easy. 9 out of 10 patients, this is in your left hemisphere. It does vary a little bit depending on what your dominant hemisphere is. So if you're left-handed, your right hemisphere is your dominant hemisphere. A certain percentage of those patients will have their language centers over here, but it's not 100%. 90% of patients, regardless of their hemisphere of dominance, it's in the left hemisphere. The reason that's important for us is that one of the things that we need to do is we need to be thinking about, okay, if I've got a patient that's having difficulty with their language, which side should I expect them to have deficits on? Yeah, it should be the right side. Those are what we should be seeing. Doesn't mean it's an absolute. There's people out there that have their hearts on the wrong side of their chest. There's lots of things out there. So these are general rules. I'm not, don't go out there and go, oh, well, you've got some left-sided deficits and some language issues. I think you're just nuts. Sign here. That's not the goal. But these are the things that we should be looking for. Now the posterior circulation, again, this is another one of my soapbox things. I did some research on this in 2012 and got to present it at the International Stroke Conference. One of the things we didn't know is, okay, here's this posterior circulation. What's the big deal? And the big deal is that your vertebral arteries come up and form the basilar artery, so it's alongside the cervical spine. The basilar artery comes up and flows right along the brain stem here and up into the midbrain, and then it also perfuses the cerebellum. What's your cerebellum do for you?
Your balance.
It's balance. Yep, think sobriety test. So it's your smooth, fine motor movements. Right motor strip allows me to pick up the bottle. The cerebellar function allows me to take a drink without going and smacking myself in the head, or I can put the lid on the bottle and manipulate the bottle. If I've got cerebellar dysfunction, I may not be able to do this kind of manipulation, the fine motor skills. So if you think about it, patients that are intoxicated, when anybody here in law enforcement? Anybody participate in sobriety tests just for fun? Purely for academic purposes. When they have you do the heel to toe test, put your heel to toe and you walk a straight line and they tell you a certain number. The number has to do with memory. Can you remember what they told you to do? But the heel to toe, they're looking for ataxic movement. That's cerebellar function. If my cerebellum is not working because my blood alcohol is, whatever, I lose that smooth movement, and so I've got a staggering gait, or what's referred to as an ataxic gait. Somebody who's had a stroke, they're going to have it typically on one half. So they can do this okay over here, but this side they can't do. They can't do a finger to nose or things like that on the side that's affected. The other thing that's fun with strokes is that nerves cross up here. In the cerebellum, the nerves don't cross. Right cerebellum controls the right side of the body. If I put a clot back here that goes into the basilar artery, it's hard to occlude your basilar artery. It's about the size of your pinky, so it's a big artery, which is a good thing. What's their outcome going to be if we completely block off their basilar artery?
Dead.
Yeah, it's a guaranteed outcome. So they're very stable, but very stably dead. So typically when clot starts to build in that basilar artery, what happens is it can spiral. It can actually spiral up the inside of that artery. So I may block off some of these branches to the cerebellum on one side. I may block off up a little higher. I may block off branches to the other side. So I've got symptoms that cross the main line. I may have numbness and tingling on one side of my body, and I end up with some sort of a facial droop or weakness on the other side of the body. So if we typically have always had it drilled into us that stroke patients have symptoms, and it's right down that midline. And that's an easy stroke to identify. If they've got something that stops at the midline, yep, that's a stroke. That's something happening up here in the brain. If it crosses the midline, it's in that posterior circulation. It's in the basilar artery, where the posterior cerebral arteries up here a little bit higher. And that's the area that's perfusing your brainstem. So you can see, even with a clot, you can see decreased levels of consciousness, sleepy, somnolence, that kind of stuff. So if you see that, it's either a bleed or it's something happening back here in the brainstem. And that's bad. The good news is, of all the clots that are, if you had to pick a clot to go after with a mechanical thrombectomy or an aspiration catheter, this is the one you want. These are, in the grand scheme of things, for the people, yeah, it's not like I do this at home. The doctors that do this is easy. They will go after basilar arteries all day long. And those are the ones that do well even out to 24 hours and now past the 24 hours. So that's really important. And again, they may not have, because the areas of the brain that are affected, it's this posterior area, it's the cerebellum, the occipital lobe. they may not have any arm drift, they may not have any facial droop, they may not have any speech problems. Instead, they've got balance issues, they've got ataxic movement in one half of their body, they've got nausea, vomiting, they've got other types of things that aren't your classic stroke symptoms. The reason that's important to us is, does anybody remember what the actual percentage of patients, ischemic patients that have posterior circulation strokes?
5%.
Nope.
15.
50,
Mm,
45?
it's 40% of strokes. And again, that's my soapbox issue, because that was the research I did. So we didn't know that until we started looking at it and said, hey, okay, and it was retrospective chart-related research, so it's not super pristine, but since that time, other people have reproduced it basically all over the world, and they're coming up with the same thing. It's about 40% of ischemic strokes are occurring in that posterior circulation. So that's really, really important. If all we're doing is the the FAST exam, which is the Cincinnati Pre-Hospital Stroke Screen, we are missing 40% of our strokes, plus the 5% of the leg ones, that anterior cerebral artery. So we could be potentially missing 45% of our ischemic strokes. And that's the reason why we're really promoting the B-FAST. In B-FAST, if you look at the B and the E, you're adding balance and eyes. So are they having balance problems? Do they have a deviated gaze or a preferential gaze? Are they looking off to one side? Or do they have a visual field cut? Because remember, your occipital lobe here is, that's your vision center. So the light comes in through the eyes, through the lens, and through the iris, and hits the retina, and then it goes along the optic nerve, and this is where it's interpreted. This is how we interpret what we see. So if we put a clot back here at E, we end up with something that looks like this. It's a visual field cut or a visual field deficit. I can't pronounce the big words, the I'm not even gonna try. So this came from an ophthalmology chart, so not from a stroke chart. But we have binocular vision. We see the same thing out of each eye, as opposed to chameleons and lizards and whatever else that is out there running around in the forest. When we see something, our brain interprets that because some of the nerves cross, some of the nerves go back this way, and so we see the same thing in each eye. So if I have a visual field cut, what happens is I can't see half of the picture. So, Chris, what do you see in the picture?
Cookie jar.
Move right to the cookie jar. What else?
Got lady washing dishes, kids, water's running over.
Okay, there's about 5 seconds. I've already got the start of a good neurological exam, not psychological, but neurological. So, was he able to answer commands? Was he able to do what I asked him to do? So Wernicke's area is working. He's receiving the commands and he followed the commands. Did he have any slurred speech? No dysarthria. Did he have any problems with getting the speech to come out or finding his words?
No.
Nope. And did he see both sides of the picture?
Yes.
Yeah. If he had a visual field cut, right visual field cut, he would have seen the kids on the stool and the cookie jar, which he did go right to the cookie jar, but not seen anything on the right half of the paper. If he would have had a visual field cut on the right side, he would have, or on the other side, he'd get vice versa. Now, it doesn't work as well across the room on a screen, but one of the things you can do is, you're in the house with Mrs. Jones where, you're doing some sort of a neurological assessment, pick up a piece of mail. Tell me, can you see the stamp? Can you see the return address? If they've got a visual field cut, they're not going to see one of those. The other thing, you don't even have to have anything. You can actually just check their peripheral vision. If you do this to yourself, start back here and see, as you bring your hands forward, you start to see peripheral vision right about here. If you are, interacting with the patient, you say, okay, I want you to look right here at my nose. Tell me when you see my fingers. How many fingers? 2 up here, 2 over here, 2 down here, 3 over here. If they've got peripheral vision, they don't have a visual field cut. And again, it's an acute onset. So people that have had strokes and they know that they've got a visual field cut, they'll cheat. And it's not cheat, it's accommodation. They've learned that, oh, you know, I can't read this without turning my head and doing this. But they've accommodated for that. Other things that are weird is your brain will play tricks on you. If you take the family portrait off the wall and say, hey, tell me who's in the picture, their brain will fill in the parts they can't see. So they'll name everybody in the picture because it's something that's very familiar to them. So piece of mail, a magazine, something you have in your clipboard, anything like that is fair game. Just to have them look at it and see, do they have a visual field problem? So by adding B and E to our FAST exam, the B FAST, that actually increases the number of strokes we're going to catch. Now, interestingly, it still doesn't do anything for that leg, that anterior cerebral artery. So we're not testing the leg anywhere in here. Yesterday, I was in Ottumwa, one of the paramedics there, he goes, I just always assumed that when we're doing arms, we do legs too. I was like, okay, good for you, that's a good thing. So once you've got them on the cot, can they lift up their leg? And when we do the race score, which I know you've seen the video before, but that's one of the things they talk about is, you know, we're going to do arm drift, we're also going to do the same thing with legs one at a time and see, because that's, you know, again, maybe only 5% of our strokes, but when you do see it, it's dramatic. Was up in a little town, small fire department up north, up by Mason City, and I was talking about this, and the guy in the back starts doing this. I'm like, and he goes, and he pulled up his phone. His wife had that stroke. And he's got a video of her walking down the hallway of the hospital, dragging her leg. And that was the exact stroke that she had. So I don't know if they got it in a treatment window or not. I think she just is going through therapy to get it. But so they do happen. So our videos, everybody doing okay, or you need a break, or everybody good? Very good. Bueller. I said that one time in a paramedic class, and everybody said, "Who's Bueller?" I'm not that old. Come on. So this is one of the things that's I say it's fairly rare. I have not seen it a lot. Stroke coordinator from Mercy, when she was at a tumble with me the other day, and she goes, "It's not as rare as you think." She goes, "Part of the problem is we don't look for it. So if we don't look for it, we don't find it. But this is that inattention." And it typically happens, it's a right hemispheric thing. I've never seen it in the left, and a lot of the stroke neurologists have said the same thing. Terry, the stroke coordinator at Mercy, she used to work for the National Institutes of Health. And so she's been seeing, she sees all the really, really weird stuff. So she says, it can happen in a left hemispheric, and you can have right-sided neglect. That's super, super rare. As a general rule, this is rare anyway. But if you don't know what you're seeing, it's going to surprise you, because you don't know what to call it. It's just some sort of a psychological conversion disorder or something. In this case, patient in blue, so young patients do have strokes too. Guy in the gray is an occupational therapist, and he's working with him. Guy in the blue has already had his stroke. We're beyond a treatment window, but he has a left-sided neglect. And I don't know if I've got audio with this or not here. I may have forgot to turn. Is it volume on one of these?
Yeah, you might have to turn the TVs up.
Will the same one work on both?
Yes.
Yep.
See how that goes. So in a left-sided neglect, in this case, the left side of his world's gone. It's not that, it's not a visual field cut. His vision is fine. But because of the stroke that he's had in that right hemisphere, it's played a trick on his brain to where the left side of his world is gone. And so you'll notice that as he's working with him here.
Is, you know how when you teach a child to cross the street, what do you tell them to do? Before they cross the street, what do? You gotta look both ways. Look both ways, exactly. So with any activity, what I want you to do is I want you to practice looking both ways before you start any activity, okay? So look to your right first, and then look over to your left.
He now thinks he's looking to the left.
Come on over here. So
He's dead center.
I want you to
That's his brain telling him that this is left. Now with stimulation, he can look to the left. And that's what the therapy is guided for. And this is long-term therapy. This takes a long time. But to teach him that this is no longer left, you have to
So we're gonna start out
do some sort of a trick or tip or something to get yourself to start looking left.
Okay.
Because unfortunately, half of the buses that are coming to mow you over are coming from the left. So, now fluent aphasia, this is Wernicke's area. This one I think it was described to me once many years ago that it's more rare than Broca's or expressive aphasia. Expressive aphasia is pretty common. Wernicke's aphasia is a little bit more rare. Once again, part of it can be because we wrote it off as being confused. We asked somebody to do something and they went off on some other rabbit hole, and we didn't know that it was a stroke, so we didn't pay attention to it or give it its due. In fluent aphasia, this gentleman has already had his stroke, and if you were, I know you remember parts of it because you were describing it, but it's kind of interesting. If you didn't know that he had a stroke, he sounds a lot like some other patients.
Hi Byron, how are you?
Sorry.
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment. Talk with the people over them over there. They're diving for them at the moment. But they'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment they don't show a darn thing.
With the iPad that we were doing. Like here?
I'd like my change for me and change hands for me. With Happy. I would talk with Donna sometimes. We're all with them. Other people are working with them. I'm very happy with them.
Good.
This girl was very good. And happy when I play golf. And hit other trees. We play out with the hands.
I play golf. I
We
hit
save
trees,
a
too.
lot of hands on hold for people, for us. Other hands. Of what you get, but I talk with a lot of hands for him. Sometime. Am I talk of any more to say?
All right, thank you very much.
Thank you very much. I appreciate it, and I hope the world lasts for you.
Thank you, it's been
I
a
still
pleasure.
love that.
Bye-bye.
That's a great way to end a conversation. I hope the
I'm
world
gonna
lasts.
start doing that. I hope the world lasts for you.
Yeah. Yeah, it's like, oh, do you know something I don't? But, so if you didn't know he had a stroke, what do you think? What else could it be?
Dementia.
Yeah, that's a picture-perfect dementia. Whether it's Alzheimer's or cognitive or vascular, there's all sorts of different types of dementia, but that's a real picture-perfect display of it. Now, the interesting part about it is, if he were a treatable stroke, if he presented with this, and we got all of his meds, we did everything that we were going to do, we found his last known well, and we whisked him off to the hospital, and they gave him a thrombolytic, and he was a candidate for it, and his symptoms went away. He wouldn't know that that was the conversation he had. To him, he had a normal, reasonable conversation. If you show him that video, he'll think you doctored it, or that's not him. He won't believe it, because he just sat down and had a nice conversation. Wernicke's area is messed up. When she asked him, what were you doing with the iPad? I don't know what he heard, but his reply was, well, we're not doing a darn thing. Don't know what he actually heard. But if we can fix that stroke, he won't have remembered the conversation as what we just saw it.
Is he gonna write out those same words you asked him to write down what he's saying?
Sometimes. Now, since he didn't have any expressive aphasia, he would probably be able to write down the words. The problem is when you ask him to write something down, he may get up and go get the milk out of the refrigerator because he didn't know what you asked him to do. You said, can you write this down? And some of the tactics that have worked for that, and it was in the Iowa Stroke Conference, they talked about this in some of the rehab tracks. Some of the things that you can do is you limit your questions, and I think they said no more than 6 words. And only one command at a time. Because if you give them 2 commands, take the pencil and write down your name. They might take the pencil, but they didn't get the write down your name part. So, I need you to take this pencil. They take the pencil. Write your name. And they may be able to actually follow those commands in short terms. So, and it's very difficult. Again, that person, if we just met him, he's either got dementia or he's confused or what. One of the stories that I tell is the first time I saw this in an EMS setting, I was already working on stroke teams. I'd seen this before. I knew what it was, but we got called to an assisted living place for a lady with an acute onset of dementia. It's like, you can't do that. That doesn't work that way. And you know, she was sitting there in her room just babbling away, and she didn't come down in time for breakfast. So they went up to check on her, and she was just sitting there, and when she went in, that was the kind of conversation they had, and their concept was, oh, it finally happened. She finally caught dementia. You know, so it's like, no, that's not what's going on. And then this one had a lot of popular play on YouTube. This is the broadcast journalist live on TV on a news channel, and this is expressive aphasia. So this is Broca's area.
Is the big winner tonight with 5 Grammy Awards, rapper Eminem, the big shocker, winning only 2 despite 10 nominations.
Not only the speech patterns, but watch her face and see if you can pick up anything there.
Coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go ahead, Terrace English for the bit, the head of the pit. We had
What'd you see as far as in her face? Did you notice anything? And it's not subtle like a droop or anything like that, but could she hear what she was saying?
She looked concerned.
Oh yeah, concern's a good way to put it, yeah. She looks scared spitless.
Yeah.
All of a sudden, she knows what she wants to say, but that's not the words that are coming out, because Broca's area took a hit for whatever reason. And so that was, they found out later she did not have a stroke. Her symptoms resolved on their own by the time EMS arrived. And the crew spent a long time trying to convince her to go to the hospital, and she would not go. So whether she had a TIA, whether she had a complex migraine, there's a variety of things that could have caused that, but she sure needs to be following up with a neurologist or a hem-onc person or somebody. She's got a clotting disorder, or she's got something going on that needs to be looked at, because that's way too young to be having that happen. So, so we already know, and again, this gets into stuff that you already know. If we find the stroke, that's our job. That's the job of the ER folks when the patients come in by car or whatever. We have to maintain a high index of suspicion that this is potentially a stroke. We use, whether it's the BFAST, we'll look at race here in a little bit, but do some sort of a neurological exam. And because we don't do it very often as EMS providers, use some sort of a tool. Use a sticker on the wall, use an app on your phone, use something so that we don't miss one of the letters of BFAST, or that we don't miss one of the tests in the race score. If we try and do it from memory, we really run the risk of missing things. So, you know, the stroke nurses and the folks in the high volume centers, they do multiple NIH stroke scores daily on patients. And yeah, they've got it committed to memory. This is what they do. And the stroke neurologists, this is what they do. So, but it's, you know, we do a lot more than that. We cover all types of emergencies. So, there is still a little bit of controversy. The controversy is pretty much going away. We're not seeing a lot of that anymore. But we still do see a little bit of, you know, a friend of mine who's an emergency, he's board certified emergency physician, very good doc. But when he was doing his training was back in the late 90s. That's when TPA was first approved in 1996. And he was involved in a case where they gave TPA and the patient ended up bleeding in his brain and had a bad outcome. Don't know whether he died, he didn't get into details. But as he said, he goes, how long do you think I'm gonna remember that? It's like the rest of his career. So now, anytime he sees a stroke, he makes sure he's got somebody else he's double checking things and saying, you know, I think this is a stroke, this is a thrombolytic, or not, yeah, this is a thrombolytic candidate we can go ahead and give. This is what I'm thinking. Do you agree? And whether it's the stroke coordinator, whether it's the neurologist, whether it's another one of the ER docs, there's just a little bit of hesitation because it's natural. You know, that's what happened to him, and that was what his experience was. So there's still things that are built in as delays that we need to try and eliminate as much as possible. We talked about the FDA stuff already. We talked about thrombectomy. There's really not an FDA. If there is an FDA limit on thrombectomy, I don't know what it is. It may be 24 hours, but a lot of the places are going beyond it and doing off-label. We talked about those already. This is the study that, and it was out 2 years ago or 3 years ago, so I may have already told you about it. Rhode Island, anybody remember talking about Rhode Island study?
I'm pretty sure you did last year.
Yeah, I thought we did. In a nutshell, you go out east, you got Providence, Rhode Island, big metropolitan area, size of Des Moines. They've got 8 hospitals. They straddle the state line between Rhode Island and Massachusetts. 4 hospitals are on the Massachusetts side, they're all primary stroke centers. 4 hospitals on the Rhode Island side, they're all stroke centers. There's 1 comprehensive center, they can do thrombectomy. The other 3 are primary centers, they can't do thrombectomy. So the Rhode Island EMS Bureau changed their statewide protocol and said, we want you to use this large vessel screening tool. They're not using RACE, they use the LAMS score, the Los Angeles Motor Score. And they said, if you think your patient is having a large vessel occlusion, we want you to take them directly to the comprehensive center. Don't go to one of these other stroke centers. They're good centers, they treat stroke well, but they don't have the capability to do thrombectomy. And they recognize the fact that if I go from if I stop at one of the other hospitals, I've now built in a delay. So it's referred to as the door in, door out time. So I've built in a delay to get that patient to thrombectomy. Massachusetts didn't change their state protocol. They go to the closest primary stroke center. So if you lived on the Massachusetts side of the line, you went to one of the 4 stroke centers over here on this side. So it's kind of the government designed the study for them just by default. So they started looking at prospectively, that was the good part. They wrote up the criteria and said, we're going to look at these things, and for the next 2 years they started collecting data on patients. The no-brainer part of it, no pun intended, the no-brainer part was, gee, if you need thrombectomy and you've got a large vessel occlusion, if the ambulance takes you directly to the hospital that can do that, it happens faster. Wow, there's a revelation. Okay, so the parts that came out that are more exciting about it are they looked at, from all of the hospitals were involved in this study, all the primary stroke centers, so all 8 hospitals were involved, and they looked at outcome data. We don't see that in the EMS world very much. In stroke world, if you're a treated stroke patient, if you were given a thrombolytic or you had a thrombectomy done, the stroke center is following up with you as best they can at, and I don't know, it's 30, 60, and 90 days. Does that sound right, or do you know, Haley?
I just do quarterly.
Quarterly? Okay.
Yeah.
So yeah, so it's basically a 90-day. And that was the key, was they do what's called a modified Rankin score. In other words, it's your activities of daily living. How are you doing after you had your stroke? Can you dress yourself? Can you feed yourself? Do you need assistance with getting dressed or toileting? All those things. Patients that came in by car to any of the hospitals, any of the 8, versus patients that came in by ambulance, they were not doing as well at 90 days as the patients that came in by ambulance. First time we've ever had proof that EMS makes a difference in the outcome of the patient. Now, this is just stroke patients. It's just in Rhode Island, in Providence, Rhode Island, but that's pretty translatable. That's pretty easy to see that we make a difference in those cases. They also showed that patients that came in by ambulance, this is kind of another duh one. If you come in by car versus coming in by ambulance, your CT scan was quicker, your evaluation by a physician was quicker, your treatment rate, so the number of patients that needed treatment, that got treatment, in other words, the ones that fell through the cracks, predominantly came in by car. The ones that came in by EMS didn't fall through the cracks. So there's a lot of good data that's just beyond the thrombectomy stuff that they did that says EMS works. And they published that. It was actually published in the American, I'll butcher it, I can't remember what it was. It was American Journal of Neurovascular Surgery, I think. So it's a peer-reviewed journal. It wasn't just, and I like GEMS, I like the trade publications, but it wasn't a trade publication. It was a peer-reviewed journal. So they looked at the data and said, yeah, you're right. This is legitimate stuff. So that's really cool. If you hear about tenecteplase, it's abbreviated as TNK. Alteplase is TPA. That's what was studied back in the early 90s. That's what the FDA approved. Tenecteplase is another drug. It's very closely related to TPA, and it's made by the same drug company. It's made by Genentech. We've been using it in hearts for about the last 15 years. So if you don't have a cath lab and you're having a STEMI, they'll give you this drug to dissolve the clot in the coronary artery. And it works, and it's a good clot-dissolving medication. but it wasn't ever FDA approved for stroke, and the reason was it was never studied. And the problem we run into in the United States is we've already got a drug that is FDA approved for stroke. Well, to come along and say, hey, we want to test this drug for stroke also, that's a very, very expensive process. And oh, by the way, did I mention it's made by the same company? So they didn't really have a dog in the fight. They've got the market cornered. They don't have a need. There are some other people that funded some studies, and there were studies that were done in other countries that looked at this. And they said TNK is safe, and it's not inferior. And then the most recent one said that it works just as well as TPA. And the FDA approved it, and again, the stuff that comes out new, this was 3 weeks ago. The FDA approved it for use in stroke. Now other places were using it before it got approved, but now that it's been approved, more hospitals are jumping on board. The nice part about it is, if I use Alteplase, the TPA, they get a bolus dose, it's weight related, and then they get the remaining dose over the next hour. And so it's done by an infusion pump. And again, it's not an innocuous drug. You're putting a drug into their body that dissolves all blood clots. So there are some risks involved in that. And we want the dosing to be specific. So we go bouncing down the road with an IV pump and an ambulance. What happens to some of that, what happens, number one, to the IV pump? If you haven't hit it with a hammer several times. Yeah. You get lots of bouncing, lots of air bubbles, so you end up having to purge the line. Where do you purge it? Do you purge it into the patient, or do you purge it on the floor of the ambulance? Yeah, well, there is a very specific amount of drug in that bag. You just lost, 30 cc's, not 30, you lost 10 cc's of that drug. Well, now the patient's not getting a full dose. And so that's important in this particular drug. So long and short of it is, TPA is not EMS friendly. You can do it, but it creates some problems. Tenecteplase is a single bolus dose. It's still weight related. It's, I don't remember, 0.25 per kilo, maximum of 25 milligrams. It's a single syringe. And it's given as an IV push basically over, do you remember what it is, Haley?
5 seconds or something?
I know it's basic, it's a minute or less.
Yeah.
And kick them out the door. There's no IV infusion to follow it. So that has big implications for us in Iowa. There were a lot of rural hospitals that would not send that patient on for thrombectomy or on to a primary or a thrombectomy center because they would wait for the TPA to be done infusing. So they're putting an automatic 60-minute delay in getting that patient out the door. For a variety of reasons. All of them, everybody has to work out their own systems. And some legitimate reasons for not doing that. The Tenecteplase takes that away. So cost is also a great feature. A single dose of Alteplase is, I think, around $11,000. A single dose of Tenecteplase was $800. Now they're made by the same company. Everybody's starting to use Tenecteplase. There's tariffs involved. I don't know. There's tariffs and there's executive orders and all sorts of. But anyway, I wouldn't be surprised if the drug company raises the price for Tenecteplase. Not anything we have to worry about in the EMS world.
Same pharmacokinetics or whatever is.
Yes, it's almost identical. I was a chemistry major once upon a time, and I actually read a little bit about that. The molecule is nearly identical to TPA. It's a different isomer. They've twisted some of the stuff around a little bit differently. Other than that, it's a very, very similar molecule and operates the same way.
Half-life and all that's the same.
Yep, half-life was, from what I understand, the half-life is the same. The onset of action is actually maybe a tad bit quicker. And what they're anecdotally, what the nurses think, the nurses that have been doing this for a while, Terry and Mercy, they've been using it for a couple of years. She believes that they have that their bleed rate is actually going down. It may actually have a lower bleed rate, and she believes that they may actually be getting a little bit more resolution of symptoms. So it may be more effective as well. Those numbers will come out. That study is being done. Alteplase versus Tenecteplase. To my knowledge, it's not done yet. They have enough information to say, the FDA to say, yes, you can use it. But whether they've studied it, the head-to-head study I think is still going on. Did anybody talk about that at the stroke conference, or do you remember,
Not that I
Haley?
remember, but I think you're right.
Yeah, there was a lot. There wasn't a lot on the acute treatment this year for the conference. So now this LVO writing criteria, once again, if you read a study or you read something that somebody else is doing in another part of the country, you have to be able to translate it. It has to be translatable to what we do in Iowa, whether it's in Red Oak or in Des Moines or whatever. This study is actually very translatable to the Des Moines metro area. Des Moines metro area has 7 hospitals. They've got 2 primary stroke centers. One has the ability to do thrombectomy, one does not. They've got the same population base of about 350 to 400,000. It's a little more dense population out in Rhode Island, but basically things are really the same. So what this means in the Des Moines area is that the EMS agencies, they're all using some sort of a screening tool, and RACE is what they had decided, what everybody decided to use. So they're doing a RACE score on the patient if they think they're having a stroke, and if their RACE score is 5 or greater, they're basically telling the patient, it's a lot like a trauma alert. If you've got a gunshot wound to your chest, you're not going to one of the community hospitals, you're going to a trauma center. If you have a RACE score of 5 or greater, we need to take you to Mercy Hospital because they have thrombectomy capabilities and we think you need it. Now, patients can always refuse, but as a general rule, that's what's changing things in EMS, and it's also changing it in a lot of metropolitan areas. Stuff that you read, if you're reading NGEMS or reading any of the peer review stuff, or they cite the articles, and there's a confusogram protocol thing that Hart's put out that it's really well written. It just doesn't project very well, but it talks about should you go to a center that can do thrombectomy versus going to a non-thrombectomy center, and it gives you a decision tree to make those decisions. That's pertinent in Houston and in Miami and in Memphis and in Cincinnati and in New York and in, if you're looking at major metropolitan areas that have multiple stroke centers, this changes what we do in EMS. Doesn't change a whole lot about what we do in Iowa. What it can change is the fact that, we can look at what part do we play in greasing the wheels to get that patient to thrombectomy? And all the patients here, or the majority of the patients here, are going over to the University of Omaha for thrombectomy. How do we get them there? And how do we do it in a shorter time? And it could be that, for your department, you've only got a very small piece of that, which is the initial recognition, notification of the hospital. Is there benefit in using a large vessel screening tool? All your patients are going here to the hospital at Red Oak anyway, but is there a benefit? And then I'm purposely looking at Haley. She's the one that makes the decision. She's the stroke coordinator. Is there a benefit in doing a large vessel screening? Can the hospital benefit from that at all? I don't know the answer. Every hospital and every EMS system is going to be different. In Mason City, they said there's really no benefit in us taking time to do the exam. We'll do it on the way to the hospital, but all of our patients come back to Mercy One, Mason City. We're not going to any other hospital. So,
Red Oak Rescue, you're needed at 510 North 5th Street, apartment number 2, for a 14-year-old female having a mental breakdown, threatening suicide.
stroke.
2022.
I'm still on you. Okay. You're chasing 40? Yeah.
So this does have some impact in various areas of the country, and even in Iowa. I think last time I talked about what some of the places are doing around different areas of the state. So we'll look forward to that. We'll come back to the race score here. I had a slide in there that had the map, and okay. So everybody's doing things a little bit differently. Up in Spencer, while they're in the living room with Mrs. Jones or the bedroom or whatever, if they think this is a large vessel occlusion, they call back to the hospital and say, hey, this is what we've got, and the hospital launches the helicopter out of Sioux Falls. So they may still only be 10 minutes from the hospital, but that 10 minutes, the helicopter can make pretty good progress. They can at least get spun up and be airborne And they've talked about this in advance. They didn't just say, hey, we heard a little bit about stroke at a conference last week, and I think we're gonna call a helicopter. So they, the helicopter systems, both of them in Sioux Falls have said, yeah, we agree, we're gonna do this, because we know it's the right thing to do for those time-critical diagnoses. And that decreases the amount of time. In Decorah, they're doing something a little bit different. They're calling in and talking with medical control. If they've got a race score that's high or they think it's a large vessel occlusion, they make sure that the patient is not a candidate for thrombolysis. They can't get TNK or TPA because they're outside the window, or they take some, take some of the factor 10 anticoagulants, things like that. They can't get the thrombolytic. Then instead of bringing them into the hospital, and they make that decision in conjunction with online medical control with the physician, instead of taking them to the hospital, they take them across the street to the helipad, which is not on hospital property. And so there's no EMTALA issues, they don't have to come in and get all their scanning done, and there's no delay. They actually tier with the helicopter that's based right there, and they fly them up to, it's not on this map, but they fly them up to Gunderson, which can do thrombectomy.
It's really surprising that the Spencer Hospital is not even a primary.
Yeah, I was kind of surprised too. I don't know why they haven't become one. I don't know what their volume is, and I don't know if it's, the other thing that they can do is that there's a certification that's called Acute Stroke Ready Hospital. None of the hospitals in Iowa have really done that. It's like it's the next step down from being a primary stroke center. And what it does is it shows that you've got the processes in place to get that CT done within a recognized time frame. You've got a thrombolytic in your hospital, in the formulary. You've got a provider that's on duty 24 hours a day that can prescribe it, whether they're a mid-level or a physician. And that's really, I think, all of the criteria. And you can get certified as what's called an acute stroke ready hospital. None of the hospitals in Iowa have really pursued that. Mission Lifeline is trying to get them to do that because they get some benefits for that with using the Get With The Guidelines tool and some stuff like that. But these are the primary stroke centers. They're the green triangles. The ones that are circled in red can do thrombectomy. And then the drive times. Drive time, the dark gray is 30-minute, then 45-minute, then the light gray that barely shows up is a 60-minute drive time to the primary stroke centers. The green that's overlaid, you can kind of see they've got the helicopter circles are laid over this. And that's within an hour flight time to a thrombectomy center. And all of Iowa is covered, except for the poor people who live on that farm in Palo Alto County. So, which in one of my classes I found one of them. They said, that's my parents' farm. I said, tell them not to have a stroke. But I think, and we know helicopters don't always fly. We got bad weather, we got a variety of reasons, maybe they're already out on another call. So there's a variety of things, but it can still be part of the system and the solution for greasing the wheels. I don't think we're to the point where we're gonna promote, we show up at Mrs. Jones' house and we do an exam and we go, oh by golly, I think this is a stroke, and then we do a race exam and she's got a score of 8, and so we land the helicopter in her front yard and send her off to Omaha. I don't think that's probably where we want to be, because there's a lot of things that mimic stroke, and we don't want to fly her off to Omaha and find out that she was septic, or that she had a migraine, or there's a variety of things. So the system does work to come back to your local hospitals. We just need to try and whatever we can do to minimize the time to get them to thrombectomy, it's the more brain we save. So the race score, this will be the last thing, we'll talk about that, and then we'll just, if you've got any questions, or we've got some case studies we can do if you want, or I know Haley's got some stuff to go over too. This is out of Miami, it's Palm Beach County, Florida. It's the same one that we saw last time. This is one of the better videos that I've seen on YouTube, even though this is from 2017. There's several out there on YouTube
now, this is not
that talk about the race
Cincinnati
scale.
stroke scale, which we're going to use as a screening tool. Most of the Cincinnati stroke scale is actually existing on the race scale. So what you'll do when you come to a suspected stroke case is you're going to do your normal Cincinnati stroke scale, which is going to be your face, arms, and speech. And if you suspect a stroke, then the next step is to do a quantitative test to see how severe is the stroke. The reason for that is because the comprehensive stroke centers, if you will use this score to open up the cath lab before we get there, kind of like what we do with STEMIs and 12-lead EKG transmission. So it's very important that once you suspect a stroke from your Cincinnati stroke scale, that you then complete this scorecard, which we're going to go over here in just a few minutes. Now, I'm not going to explain all the details behind the race. Dr. Moskowitz.
That scorecard is in your folder. It's also, if you've got one of the little laminated badge buddies, it's on, it's BFAST on one side and the race scores on the back
side. So first we're going to
side.
start with, just like in Cincinnati, we're going to start with facial palsy. So you're going to ask your patient to look directly at you, and you'll just look at the camera here and make a big smile.
Excuse me.
And what you're looking for is symmetry of the mouth. And if there's symmetry, there's a score of 0. If there's a slight disfigurement, you know, if one side's slightly lower, you're going to give it a 1, and if one side just doesn't move at all, you're going to give it a 2. Next thing, just like Cincinnati stroke scale, you're going to have the patient raise their arms. So you're going to have both arms, you want them palms up preferably, and you're going to do a count to 10. If one arm starts to drop before the count of 10 but doesn't hit the ground, that would be a 1. Obviously, if they keep them both up for 10, that's a 0. And if one arm just can't even lift up at all, that's a 2. So again, it's a severity. Both arms out and they hold for 10 seconds, 0. One starts to drift but doesn't hit the bed within 10 seconds, that's a 1. They can't lift one up at all, that's a 2. Next is going to be just like we do in our old stroke evaluation, just like we do for the arms, we do the same thing for the leg, but obviously you can only do one leg at a time. So you have the patient lift one leg up 30 degrees. You're going to do a 5 count for this. If the patient can hold it all 5, that's a 0. If it starts to drift down during the 5, that's a 1. If they can't lift it up, that's a 2. So again, similar to stroke evaluation we've done before, we're just grading it. Now these next two things, and you're going to see it that we've actually put a little black box around these. These are really important ones because the stroke neurologists at the comprehensives are really asking that we put these two in our ENCODE reports to them. Because each of these individuals have a high correlation to patients that require brain catheterization, regardless of the score. So as far as the score itself, a score of 5 or greater has a high likelihood of either being a large vessel obstructing stroke or perhaps even a bleed. So those patients obviously need comprehensive care. But individually, if either one of these two things are present, that also raises the odds that it's going to be a large vessel obstructing stroke.
Those boxes
so
are not highlighted on the sheet that you
so
have.
if you're looking at the patient,
that was something they did specifically for their protocol.
We did do this on our last stroke evaluation on how you check visual. This is basically looking for gaze deviation. When people become blind on one side, they look at what they can see. So you might see your patient looking only off to one side.
And this is actually very oversimplified.
So the left side, that's because they'll be looking at what they can see, and they'll actually won't be able to see this side over here. So if you come up on a patient and they are deviated, either their head is turned, or their eyes are turned, or their mouth are turned, that is a positive. And that is a very important sign of a large vessel obstruction stroke. So that's what you're going to see. And you notice on this one, it's either absent or present. You only get a 0 or a 1. So if the patient's able to look at you and follow and can look at both sides and turn their head both sides, that's a 0. If they're deviated off to one side, that's a 1, and that's a very important one to transmit during your ENCODE. The next one is this thing called aphasia, and that's basically, it's not slurred speech, it's inability to understand commands is what we're testing. You're going to ask the patient to do 2 things. So the first thing is going to be, close your eyes, and that's 1, and the other one's going to be make a fist. Now if the patient can do both, that's a 0. If they only do one of the 2, that's 1 point. If they do neither of them, that's a 2. It's important when you ask the patient to make a fist that you're making them have the fist in the hand that they can still move. The fact that you can't move the hand that's already weak, that's a non-finding. This is really a test of their ability to understand. So can they understand to make a fist? Yes, but you can only ask them to make the fist in the side that they can still move. That's how you're going to score that one. So again, or present, that's an important thing. And then we do have this one sort of strange stroke symptom when you have left-sided weakness, that sometimes the patient, while they can speak, they don't and they're weak on their left side, they don't recognize the left side as being theirs. So this last one, this agnosia, this is basically all about this. The patient recognizes the left arm as being their arm. You're going to see this only if there's left-sided weakness. It doesn't generally exist if there's right-sided weakness. So if you've got a patient with left arm or left leg weakness, what you're going to do is you're going to say, hold up this hand and say, whose hand is this that I'm holding right here? Now if the patient says, that's mine, good. That's a correct answer. If they say it's, I don't know, that's at least 1 point for that. Then the next thing is you're going to see if does the patient recognize that the arm is weak. So let's say that this arm is weak or is paralyzed. you're gonna ask the patient, are you able to move that left arm? And if they say yes, then that's obviously a falsehood. They don't recognize it as weak, and they get another point for that. If they say no, that means they recognize that it actually is weak, and they get a 0 for that. So for this last one here, for the agnosia, it basically has to do with left arm weakness. You want to know, does the patient recognize the arm is theirs, and does the patient understand that the arm is weak? So if the patient doesn't know either one of those two questions, they get a 2. If they know one of the two, they get a 1. And if they understand it is their arm and it's weak, then they get a 0. And that's how you score it. So this is our race scale, and you'll see it.
And then, emphasis again, use some sort of a tool, use a worksheet, use something so you're not trying to do that by memory. There are several screening tools for large vessel occlusion that are all validated, that have been used. There's probably more than this. The Iowa Stroke Task Force, when we've talked about it, we've said, we're recommending the RACE. It's got the highest positive predictive value for recognizing a large vessel occlusion, but I say that with an asterisk. It's tied with VAN and LAMS. In Rhode Island, they use LAMS. Things you have to watch out for, and then this is my own personal bias, VAN is being used by some of the hospitals in Iowa to determine, is this a large vessel, or should we do the CT perfusion study, because it's expensive, and it's vision, aphasia, and neglect. So if they've got motor weakness, they've got an arm drift, then we look, do they have any visual field problems, double vision, gaze deviation, aphasia, receptive aphasia, just like in the RACE score, they can't follow commands because they don't understand what you're asking them to do, or neglect. If they've got a left-sided neglect, then there's a really high likelihood that that is a large vessel occlusion. The reason I don't like this one is that these are no-brainers. These were the boxes that were highlighted, because you don't have to have a RACE score of 4 or greater than 4. If you've got any one of these, vision, aphasia, or neglect, that's a large vessel. Well, in my mind, that's kind of like looking for, the best way I've found to describe it is, I'm looking for black and white dogs, but I'm only going to include Dalmatians. Gee, every Dalmatian, everybody fits. Everybody's a black and white dog. Well, if all you're looking for is Dalmatians, you're going to find a lot of black and white dogs. But you're going to miss the Jack Russell Terriers, you're going to miss the, the Border Collies, all the other things that are still large vessel occlusions that can be treated, but we miss them. So when you read about VAN, take it with a grain of salt. It has a very high predictive value. They're touting like 80, 85, 90% in some studies. RACE is saying 75%, LAMS is 75%. Watch out on the LAMS. If you're using LAMS, only use the motor scoring. That's part of the Los Angeles pre-hospital stroke score. And one of the things they did is they were doing research, and they said, hey, we want to make sure that we don't include anybody that's got a stroke mimic. So if you've got a history of seizures, on the top half of that form, you check it, and poof, they're not a stroke. If they've got a history of diabetes, you double check the sugar. If they've got a history of, did I say seizures already? So seizures, diabetes, there's a couple other things that they just automatically say, oh, well, this probably isn't a stroke. It's like, well, wait a minute. People with seizures still have strokes and stuff. But the bottom half of that form is that Los Angeles motor score, and that works. That works well, and it's got a good positive predictive value for large vessel occlusions, just like the RACE does. This may change. Stroke Task Force is going to meet next month. They may get together and say, hey, there's some new data out there, and now we're going to go with something different. That's the tough part and the frustrating part. Find something that works, and once again, work with Haley. She's your stroke coordinator here. Is there a benefit for you in Red Oak to do any type of a large vessel screening, or since all your patients are going there anyway, do we wait and let them do that in the ER, but just make sure we get the early notification, because that has really been shown. Stroke is a BLS call. We can do some things as an ALS provider that, if the patient's losing their airway or things like that, but as a general rule, ischemic stroke, it's recognition of the fact that they're having a stroke. It's getting the right information for last known well, all their medications, things like that. And I didn't talk much about the medications. Why is it important that we get their medications?
Just for contraindications? Or...
Yeah.
They're AFib already.
Yep, see if they're in AFib. That's a good one, yeah, if they've got a history of AFib. Some of the medications that they may be on for blood clots, the anticoagulants, those are contraindications to thrombolytics. If you are on Pradaxa, you are on Eliquis, you are on any of those, then, and you've taken your dose within the last 24 hours, you can't get the thrombolytic. If you're on Coumadin, they can draw your labs and see what your INR level is. If your INR is less than 1.7, you can still get the thrombolytic. So there's various things, but we need to make sure that we've got that information for the hospital. Because again, our stroke patient may be non-communicative. They can't answer those questions once they get there, and the family members are still calling each other and making sure that the dogs are taken care of and everything else. And we've whisked the patient away emergent to the hospital for treatment.
What did you say, Brian, about Eliquis again?
I'm sorry?
What did you say about Eliquis again there?
Eliquis, Pradaxa, Xarelto, they all come under a class of drugs called factor 10 inhibitors. So if you draw out a clotting cascade, you got all these fun things. There's several factors like von Willebrand factor and stuff. Factor 10 is where these drugs all work. Coumadin works completely different place. Coumadin works in the vitamin K channel for forming clots. So Coumadin is reversible with vitamin K. These drugs, there's some new drugs out to reverse them, but they are ungodly expensive. Like $35,000 a dose, I think.
And what did you do with the time frame? You said a time frame for the Eliquis.
The time frame for all of those factor 10s they're saying are 24 hours. So if your patient hasn't taken any of those within 24 hours, they still may be eligible for the thrombolytics. And part of the reason is we don't know. The stroke community doesn't know. It's never been studied. TPA was approved back in '96, TNK was just approved last week, but nobody ever studied it in conjunction with the factor 10s. We do know that it's safe to give with Coumadin as long as your INR is low, but there's no lab test. If you're on Eliquis, I can't draw your blood and send it to the lab and say, hey, what's your Eliquis level? That doesn't exist. So we don't know.